Assalamu alaikum. This is a presentation for medical students by Dr. Mumtaz Ahmed Umar, and today's topics are acute epiglottitis and acute laryngo-tracheo-bronchitis. Both of these conditions, they are the most common cause of stridor in children and can be mixed. So with today's presentation, we will be able to differentiate between the two conditions. So first, the acute epiglottitis. Introduction. It is also known as supraglottic laryngitis. It is the acute inflammatory condition confined to the supraglottic structures, mainly the epiglottis. Then aryepiglottic fold and arytenoids can also be involved. There will be marked edema of these structures, which when proceed will lead to obstruction of airway and can become life-threatening. So this is a very serious and emergency condition. So it is one of the ENT emergency and a serious condition and usually affects the children between 2 to 8 years. Adults can also be affected, but they are rare and they usually don't present with stridor. Stridor is main symptom in children. The most common infectious organism is Haemophilus influenza type B, but now due to the introduction of vaccine, uh, other organisms are also becoming common, like group A streptococcus, streptococcus pneumoniae, staph aureus, but still the most common infective organism is Haemophilus influenza type B. And there may be some non-infectious reasons for acute epiglottitis also, namely the trauma due to intubation or foreign body ingestion, burns due to hot liquids intake, hot fluids intake, smoke ingestion, or due to any chemical injury, which when affect this supraglottic structure will lead to edema and can give rise to acute epiglottitis. Symptoms. It usually starts with upper respiratory tract infection and fever, but the duration is short. The history will be short. The onset of symptoms is abrupt. This is the mainstay of suspecting acute epiglottitis, when there is sudden, abrupt or rapid progression of the symptoms, meaning the child may be having upper respiratory infection which is of mild nature, but within the span of few hours the condition has worsened, usually 4 to 6 hours up till 12 hours. The history will not be longer than that of the worsening of the condition. Child will be anxious and toxic looking and may present with breathing difficulty, dyspnea and stridor. It is the most common presenting symptom, and also alert the doctor, uh, because if airway is not maintained, then it can lead to death of the patient. Other symptoms are the sore throat. Patient will be having difficulty in swallowing, and there will be painful swallowing. So difficulty in swallowing is dysphagia and painful swallowing is odynophagia. These are more common in the adults, but children also have these symptoms. And as already mentioned, stridor is rare in adults. The child will be tachypneic, hyperventilating, and present with stridor. Since it's a supraglottic structure, so the stridor will be inspiratory, and the stridor will increase when the child lies supine. So the child will refuse to lie down and will attain a tripod position, in which the child will be sitting, leaning forward and extending the neck. So child prefer the sitting position with hyperextended neck, which will relieve somewhat of the breathing difficulty. But the disease is rapidly progressive and may prove fatal unless relieved. There will be change in voice and the speech become muffled along with drooling of saliva due to dinophagia and dysphagia. Though cough is rare, again the two main differentiating point between the acute epiglottitis and laryngo-tracheo-bronchitis is One is the sudden abrupt onset in acute epiglottitis and decrease or absent cough, whereas in acute laryngotracheobronchitis, the main presenting symptom is the barking cough. We will see that, and the condition takes 2-3 days rather than abrupt onset in acute laryngotracheobronchitis. The signs or the examination findings: the patient will be running high grade fever because it's a bacterial infection and due to septicemia, and patient's condition deteriorate rapidly. Direct visualization is confirmatory but in controlled setting. So for a presentation or ideal situation, only after visualizing directly the supraglottic structure one can label it as acute epiglottitis. So depressing the tongue with the tongue depressor show a cherry red and swollen epiglottis. But there is one take in this. Let me just complete the ideal, then I will come to that take. To visualize the laryngeal structure, laryngeal examination has to be carried out. So the first step in laryngeal examination is indirect laryngoscopy with the help of laryngoscopy mirror. It may show edema and congestion of the supraglottic structures, but in small children it may not be possible. So one has to carry out flexible laryngoscopy or rigid laryngoscopy. Ideal can be done in a cooperative child and adults. Now what is the take? Once any child who is suspected to have acute epiglottitis, examination should not be carried out in OPD. So do not examine the throat. Any child suspected of having acute epiglottitis, tongue depressor examination or mirror examination should not be carried out in emergency room where no facility for emergency tubation is available, and never in OPD. So never use a tongue depressor or any object to look down the throat. Now why? Because it will trigger a laryngospasm and cause the airway to close instantly, and once the airway is closed, the patient will die because of breathing difficulty and breathing apnea. Air will not go inside and he will die. So then how one should examine? It should be carried out only by a specialist or a senior doctor, again in a controlled setting, not in OPD, in a controlled setting like operation room where facility for emergency airway maintenance is available. We should have bronchoscope available, laryngoscope, endotracheal tube, everything should be available so one can intubate the patient instantly if the breathing difficulty worsen. So what investigations to carry out? As it is an infective condition, so CBC, which may show neutrophilia. Then throat swab can be taken, and blood cultures can also be sent, which will show the infective organism. Flexible pharyngolaryngoscopy, it can be carried out, but again, as mentioned, in controlled setting, and as in small children, indirect laryngoscopy is not possible, so one can pass the laryngoscope, flexible laryngoscope through the nose and examine the larynx. Rigid laryngoscopy again in small children will not be possible, only in cooperative child, as one has to hold out the tongue. And if the patient has not developed breathing difficulty, then X-ray soft tissue neck lateral view can be performed, which may show swollen epiglottis, and this sign is known as thumb sign. So again, thumb sign is diagnostic for acute epiglottitis. This question can come in the MCQ or can be asked in the Viva. Again, regarding the oropharyngeal examination, it is asked in the Viva that whether you can examine the patient in the OPD or no. So you have to be clear that any suspected patient of acute epiglottitis without senior availability or the availability of emergency airway maintenance, it should not be attempted. Okay, so the surgeon wants to hear this thing, but many students they say no, we can easily examine in the OPD, so don't confuse with this thing. So this is a normal patients in some children. When once you open the mouth or when they open the mouth widely, epiglottis can be visible without the mirror, but mostly it will not be visible without mirror. So this is the laryngeal laryngoscopic examination. The swelling has just started. If you just compare these two, it is normal, but now the swelling has started. This is the epiglottis, this is the aryepiglottic fold and arytenoids. This is the false cord hypertrophy, and this white is the true vocal cord, and here is the subglottis and the trachea. Now if you see in this picture, so this swelling has increased and the trachea becoming narrow. The opening is becoming narrow. So these once it started to develop and increase, then it may completely obstruct the larynx. So up till this stage, intubation is possible, but if the patient present at this stage, laryngo-endotracheal tube may not be passed because larynx is not visible. Then only treatment then will be not the treatment, but the only method then will be cricothyroidotomy or the tracheostomy, because to airway maintenance is the first part of treatment. And since it is an infective condition and gets settled in 2-3 days with the proper medication, intubation is preferred in place of tracheostomy. But if patient present in this stage, then intubation will not be possible. So one has to perform tracheostomy to maintain the airway. So this is X-ray soft tissue neck lateral view, and this whole swollen part is the epiglottis. This is the hyoid bone and the epiglottis is attached above here. So this is swollen and is known as the thumb sign. And if you see, this black is the airway and it is now obstructing the airway. Treatment. So whenever any child with breathing difficulty or acute epiglottitis is suspected, he should be hospitalized. So then reassurance is given to the attendant's parents, and child should be kept calm, excuse me, and avoid agitation, because the moment child cry too loud and try to move or become agitated, the breathing difficulty worsen and will risk the life. Then adequate hydration. To do that, we maintain the IV line and start the IV fluids, humidification and oxygen inhalation. Patient may require nebulizer, mist tent or a crook pet. One can use adrenaline in the nebulizer, 1 in 1000 mils in 3 mils normal saline. Intubation or tracheostomy, as I already mentioned, since this is an infective condition and get better with the medication, so intubation is preferred. But depending upon the stage and degree of stridor, so any option has to carried out if patient has respiratory obstruction. Because if respiratory obstruction is not relieved immediately, it will lead to death of the patient. So this single point is the main concern of this disease. Airway maintenance. Antibiotics, third generation cephalosporins like ceftriaxone, it is very effective against H. influenza and given by parenteral route, preferably IV route, without waiting for the results of throat swab or blood culture. Steroids has to be started, either hydrocortisone or dexamethasone to relieve the edema, and then antipyretics and painkiller like paracetamol or brufen can be given. Prevention. The Haemophilus influenza vaccine, it significantly has reduced the childhood cases, though its induction in the EPI program, and it is given as a part of the pentavalent vaccine in mainly 3 doses at 6, 10th and 14 weeks with a booster at 18 months. These vaccine has also prevented the childhood-related meningitis and pneumonia. So in summary, a toxic child with a short history of sore throat, inspiratory stridor, muffled voice, and drooling due to dinophagia and dysphagia. Pharyngeal examination, though contraindicated if acute epiglottitis is suspected, because it may precipitate acute airway obstruction. So it should only be carried out by a senior consultant in a setting where facilities for airway maintenance is available, because direct examination of the airway will diagnose the condition and should be carried out in operating room. Endoscopic examination will confirm, or laryngeal examination, it will confirm gross erythema, congestion, and edema of the supraglottic structures. Child should be intubated with these findings. I mean, if you suspect that the edema is too much and breathing difficulty is not up till that extent, but edema is severe, then he should be intubated to remain on the safe side that his condition may not worse and may lead to emergency situation. So with such findings, child should be intubated and medication should be started. Now the next topic, it is acute laryngo-tracheo-bronchitis. It is also known as croup, and it is a viral infection leading to inflammation of the mucosa with edema of the larynx, trachea, bronchi, and it is more common than acute epiglottitis. So the main, again, the another difference, it is affecting the upper and lower airway both, starting in upper way and extending down to the lower airway from larynx, trachea to bronchi, and it is more common than acute epiglottitis. It is a viral infection, mainly the parainfluenza virus type 1 and 2, and it affects the child between 6 months and 3 years. So it is more common in infants and young children from months to years, while acute epiglottitis, it mainly affect after from 2 years to 8 years. Males are often affected more, and secondary infection, since it's a viral infection, but chances of secondary infection with gram-positive cocci soon supervenes. Pathology. So the inflammatory changes, they are present throughout the airway, but stridor, when stridor, this, as I already mentioned, this is another common cause of stridor in children. Stridor develop when edema affects the subglottic area. Subglottis is the narrowest part in the children, and any inflammation in this region will lead to stridor. The loose areolar tissue in the subglottic region, this swells up and close that part and lead to respiratory obstruction and stridor. It is coupled with thick tenacious secretions and crust which may completely occlude the airway. There may be formation of a pseudomembrane, and once this occur, it will show likely feature of the bacterial laryngotracheobronchitis. So this shows the progression of the disease and its advancement. Symptoms, it usually start as an upper respiratory tract infection for about 2 to 3 days history, because it's gradual rather than abrupt onset as in acute epiglottitis. The child will be have malaise, low-grade fever, barking cough. This is the main feature of acute laryngotracheobronchitis. There will be bouts of dry cough, hoarseness will be there, and stridor, which starts as an inspiratory but then shift towards the biphasic. And both inspiratory and expiratory may be involved. And due to repeated coughing and fever, the child will be exhausted and lying down. Signs, there will be signs of upper airway obstruction, which are these are the again the signs of some respiratory obstruction. If anybody asks what are the signs of the upper airway obstruction, then it is nasal flaring, opening up of the nasal ala, suprasternal and intercostal recession, Sternal wall retraction, once the child is inspiring, there will be retraction or inward movement of the sternal wall, and use of accessory muscles of respiration like the scalene muscles in the neck. On chest auscultation, there will be decreased air entry and crackle sound may be heard. So the features is shown in this picture of LTB, acute laryngo-tracheo-bronchitis. It will be of slow onset and barking cough with growing sounds. There will be inspiratory stridor, which may progress to become the biphasic. Occurs at night and mainly in the winter season. May progress to hypoxic state due to low oxygen saturation and slight temperature. Viral temperature goes up till 101 and not above 102, and commonly occurs in young children, infants and young children with pre-existing upper respiratory tract infection. The child will be restless and may have suprasternal retractions and tachypnic. So investigation, since again it's an infective condition, so CBC will be done. But the differentiating between the bacterial infection and viral is the WBC's count. The WBC count will be too much in bacterial infection. Flexible pharyngolaryngoscopy can be carried out to examine, but again in a cooperative child. X-ray soft tissue neck, AP and lateral view are done. In AP view, an important sign which is known as the steeple sign or the hourglass sign or the pencil sign, which means there is narrowing of the subglottis. So this X-ray, it is showing hourglass, like it is wide here, then narrowness, and then wide. So this narrowness, this narrow area, it's again like nib of pencil, pencil sign or the steeple sign or hourglass sign. Again, more pronounced in this X-ray. The airway is open here, but it's too much narrow here. This is the subglottic area, and then again become wide in the trachea and lower down. So again, this question can come in the MCQ. The diagnostic patient present with this problem, and X-ray shows steeple sign. What is the most common diagnosis? So it's laryngo-tracheo-bronchitis. The patient has this symptom, and X-ray show thumb sign. What is the diagnosis? It will be acute epiglottitis. Now treatment. Again, hospitalization is important. IV line maintenance, humidification, because as mentioned, there may become thick secretions or crusting. So humidification will soften those crust and secretions which will block the tracheobronchial tree. Hydration is countered by the parenteral fluids. Steroids are the mainstay of treatment, and nebulization. Adrenaline administered via respirator or nebulizer because it's a bronchodilator and may relieve dyspnea and need of tracheostomy, because if the breathing difficulty increases, then patient has to undergo tracheostomy to maintain the airway. Antibiotics can be started if there are chances of suspicion or to prevent the secondary bacterial infection. Ampicillin can be given in a dose of 50 mg per kg per day. And if, as already mentioned, the breathing difficulty developed or worsened, then intubation or tracheostomy has to carried out. This is a very important slide which shows the different features or different points of the acute laryngo-tracheo-bronchitis LTB and acute epiglottitis. This question is usually asked from the students in Viva also, and also in presentations. So the age affected in LTB is of younger age group, 6 months to 3 years, while in epiglottitis a little older age group is involved from 2 years to 6 years. Onset is gradual in LTB, while it is abrupt and rapid in epiglottitis. LTB is mainly of viral origin, and subglottic is the main site involved, followed by the lower airway, while epiglottitis is of bacterial origin and supraglottic part is mainly involved. The main symptom is the hoarseness with barking cough, hoarse cough, while there is no cough in acute epiglottitis, but the speech will be muffled and child will be very toxic, and he will be in sitting position, the tripod position, while in LTB any position can be attained by the child. The mouth will be closed, but there will be nasal flaring, and other signs which discussed of respiratory obstruction will be there, while in epiglottitis the open chin forward drooling will be there. Fever is usually low grade or absent, while in epiglottitis it will be of high grade. Appearance, the child will not be very acutely ill, doesn't look very acutely ill, while as I mentioned in epiglottitis the child will be very anxious and looks extremely toxic and acutely ill. Radiography will show narrow subglottic area and steeple sign, whereas epiglottitis shows swollen epiglottis and the thumb sign, which is a thumb sign. On palpation of larynx, in LTB there will be no tenderness, but might see tenderness in epiglottitis. LTB will recur, but chances of recurrence is less in epiglottitis. And seasonal incidence is more common in LTB in winter, while in acute epiglottitis seasonal involvement is not there. So thank you. These are very important topics. Get used, study them properly. If any question, you can ask in the comment section. Thank you.